So let me reduce this screen. Okay, so the topic of my presentation is a specific modification of the pedicle subtraction osteotomy. And I will try to show you what is this modification, how to perform it, and what advantages it can bring. And these are my disclosures. And to start with, like 15 years ago, when I saw my first pedicle subtraction osteotomy, what I usually was observing is that surgeons, we were attempting to obtain corrections, very powerful corrections, but in reality, when you went to the X-ray, to the postoperative X-ray, and you measured the amount of correction obtained, it was not that extreme. And here you have one summary of 4 different articles published before 2012. You can see how the average correction for one level of PSO was about 25, for Keith Bridwell about 30 degrees, but very often the corrections were around 20%, and it's 20 degrees. And it's interesting that even Keith Bridwell, in between 2 different publications, had this very large interval of correction. And you know that very often you have the need to correct more than 30 degrees in one level. I'm just coming from the OR where I had one patient with a long fusion mass, a huge hypolordosis, and I have needed a correction of 45 degrees at one level. In some cases, can need as much as 70 degrees in one level. So how can we do that, especially in very rigid spine? So the point is that the main limiting factor in the angulation of PSO is the posterior height of the resection. So this height, which is limited by anatomical difficulties, especially the exiting roots above and below, this limitation causes a limitation also in the magnitude of the pedicle subtraction osteotomy angulation. But interestingly, years ago, while I was reviewing some cases in our department, I stepped into this case. As you can see, this is a very interesting case because this gentleman had a very tiny resection, The height of the resection was hardly the height of the pedicle, but this gentleman had a correction of 33 degrees at one single level. So this brought me to try and analyze an alternative for this limitation of PSO. Here you can see, if you simply reduce the AP, anterior to posterior displacement of the plane of the osteotomy, automatically you increase the degrees of corrections for the same height of posterior wall resection. This is the key in the geometry of corner osteotomy. You shorten the resection to make it steeper. So what are the requirements to do a corner PSO? The requirements are, first, that the disc space above the osteotomy can be mobilized, because making a short osteotomy, you need the upper vertebra to hinge on this part of the anterior annulus. So it's going to behave as a posteriorly closing, anteriorly opening osteotomy. You need mobility in this disc. And the second thing is that you can get exposure to this disc from posterior, that you can easily access this to remove the disc and to include it in the osteotomy. Here is the concept. Here you have 3 consecutive vertebrae. You remove the corner and you make the magic, closing posteriorly and opening anteriorly. After the first cases, we included one refinement in this corner osteotomy concept, which is using an interbody cage inferiorly in order to compress the osteotomy and to get bone-to-bone fusion at this interface. And we usually do this with a transost lateral approach. Here you can see the relevant anatomy for corner PSO. The pedicles are well highlighted by the pedicle screws. Here you can see the 2 pedicles of the osteotomized vertebra. You have the dural sac, you have the exiting roots above and below the pedicles involved. So what's important here is that after you have made your decompression, and you identify the pedicles, you be able to expose the lateralmost part of the disc. Here you can see how, here, at both sides. So here, they're showing, here you can see how we mobilize all the roots, and then we place a pencil here in order to be able to cut this space at both sides to the lateralmost part of the vertebra. After doing this, here you can see the line of discectomy. We prepare the end plates of the inferior end plate of the upper vertebra for getting a fusion in the same way as we would do for a P-leaf or a T-leaf. And finally, we dissect the lateral wall. We perform this osteotomy with a chisel that is pointing at a distance which is 2/3 of the length of the end plate. By doing this, you can easily pivot this space, opening it anteriorly and closing it posteriorly in a very sharp way. Here you can see the shape of the resection. There you can see the triangle that will resect on both sides and beneath the dura. And here you can see a video. This is Claudio Lamartina, my partner, and I doing this corner PSO. This is a video that you can easily download, purchase, and see in the Open Operating Theater, OOT platform. Here you can see we are cutting the wedge from below the pedicle towards the disc space. And here you can see how it happens. We split the fragment in order to release it in a piecemeal fashion in order to avoid injury of the dura. And that's it. You can see the 2 big triangular pieces, then you remove the remaining disc in the front, if you didn't before. And now you're ready for doing a bone-to-bone fusion around this pedicle subtraction osteotomy. You can see how the spine has been mobilized very strongly. You can see the osteotomy completed in the midline. Some removal of the end plate of the upper vertebra. And since you can watch all this video in the Open Operating Theater, OOT/ESG.com. And a very important aspect, now you can see the osteotomy completed, is that when you bend the table in lordosis, you get bone-to-bone contact, and that's important to increase the chance of effusion. I learned this from Jean-Charles Lewec, from Jean-Charles. He taught me this trick of trying to get bony contact posteriorly on the osteotomy, and this reduces actually the rate of non-union. So here is one example. This is a lady with a high pelvic incidence, 63 degrees. She has a very severe hypolordosis. Her lordosis is 1 degree, and so we need to increase that to 67. So you can do as many Ponti osteotomies as you want, and you will never get that. So we performed, in this case, this kind of a corner osteotomy. Here you can see the shape of the osteotomy. Here you can see the cage below the PSO. You can see the huge gain in lordosis in this case. We went from 1 degree to 69 degrees of lordosis in one shot. Here you can see the detail of the X-ray, how the disc opens anteriorly and closes very sharply posteriorly. Very interesting to see also in these images how the cage implanted after the system has been closed with the screws and the rods in place pushes the fragment, the weight fragment of the remaining vertebra in order to compress the fusion area between the vertebra above and the osteotomized vertebra. That's an important adjunct to increase the chance of getting a solid fusion. There you can see the clinical aspect of the lady. And here you can see one CT scan 1 year after the surgery. You can see the fusion happening in the osteotomy site and the fusion happening through the cage. This is another example of a application of corner osteotomy. This is a lady who had first surgery for scoliosis. Then she had an infection, a very severe spondylodiscitis. And if you look with detail at this X-ray, here, what I'm highlighting here, this is not the sacrum. This is part of L5 that has sunk into the sacrum. So this lady had almost complete bone resorption of L5 that eventually fused to the sacrum, causing a very severe kyphosis. Here you can see the remains of the L5 vertebra sunk into the sacrum. So you can call this whatever, you can call this L5 osteotomy, corner osteotomy. What we did in this case was cutting this remaining part of L5, that is the corner of the vertebra. And doing this, we were able to do this nice correction. Of course, with a long construct to get the control of a very long lever arm of this lady. And this patient had also very good alignment postoperatively. Here you can see the key parameters. The most important thing is that in addition to a good SVA, she has a very good restoration of pelvic tilt. And this is going to tell you that this patient has a perfect correction. And here you can see the lady 2 years postoperatively. She was on wheelchair before the surgery. She had a dropped foot before the surgery, and now she was very happy of being able to stand with no pain and with no sagittal imbalance. So these are some numbers about the comparison between corner osteotomy and usual PSO or standard PSO. And the most important finding is that in our series, corner PSO increased by almost 20 degrees the amount of correction that we got at one single level, which was very significant. So in summary, corner PSO is a technical variation of PSO. it's a closing opening osteotomy. And for that reason, you can increase the amount of correction at a single level. You have also a higher chance of interbody fusion because of the fact that you prepare and include the disc space into the osteotomy. You resect the lower end plate of the upper vertebra, or you prepare it for fusion. So you can restore the continuity of the anterior column much better. Probably takes more time, but in our series it was not very clear, because in our series the cases treated with corner osteotomy that actually took more time were much more complex cases. There were many more revision cases. There were much stronger corrections in this series. And there is one feature of corner PSO that is that you get angular correction versus doing a correction with osteotomies, where you get a more distributed. I would not call it harmonic, because harmony depends on how the shape of the spine should be. So sometimes with the multi-level osteotomy, you get a harmonic shape of the lordosis. Sometimes with a multi-level osteotomy, you get a extremely disharmonic correction. And that's it. I'm happy to share with you or to answer to any questions, to share any comments. In the case that we had still some technical difficulties with Jean-Charles' presentation, I have a backup of a 12-minute video of a real surgery with corner osteotomy, if the moderators want to use it.
Yeah, thank you very much, Pedro. This was very clear. I mean, this is a technical, really a technical issue, how you do this osteotomy, and you showed beautifully what is the key point. Just for those who would like to see this this osteotomy once more, because you showed the osteotomy in a cadaver exercise, what you presented. And as you mentioned, this is on OOT. The number of this film or this video is 15/007. And there are 16 videos under this number, and one is the PSO and one is the corner osteotomy. So you can go there on oot/esj.com and you will find it there, or you go directly to the journal. So are any questions from the participants? I'm sure Pedro will.
There is one question. Haluk Berk is asking, do you have experience in Jan Wang's osteotomy? How does the correction rates differ with corner osteotomy?
Well, I think that Mehmet, that the Y osteotomy is essentially the same thing. I don't think there is a huge difference between both. It's a closing opening osteotomy, and I think that the concept is very similar.
Mm-hmm. Yes. So in your series, do you see a difference in terms of possible neurological complications in this osteotomy? Because it's quite a significant angulation, and compared to the PSO, it's even more angulation. And is there any signs that there is a higher risk, neurologically spoken?
In our series, we didn't find differences in neurological complications, though the numbers were not high enough to be sure that this lack of difference was reflecting the truth. I believe that in any case, when you have the need to increase the amount of correction, you probably face a higher risk. I don't think that's related to the type of osteotomy, but rather to the amount of correction at a single point you have to do. So when I have a patient who needs 55 or 75 degrees of correction at one point, I tell them that there is a substantial risk. this said, I think that some being very careful of completely releasing the roots until well after the exit of the foramen. And sometimes when you begin closing the osteotomy, you realize that the lateralmost part of the higher posterior corner of the vertebra below, this can impinge on the lower root. So sometimes I begin closing and then I see this and I put the chisel and cut this part of the vertebra. So if you make sure you try to look at the roots every time in every moment, that's you reduce the risk. Something that you can do also to make sure that you get posterior bony contact and you have complete decompression is to have more posterior decompression at the sides in the foraminal area and less decompression in the middle.
Mm.
There is one question, Pedro. Dr. Firas Alobidi is asking, is there any data regarding fusion rate between corner osteotomy and pedicle subtraction?
No data, no data. I can tell you that we hoped that with corner osteotomy, the non-union rate equaled 0, but I cannot say you that. So we still see some non-unions. My impression is that in corner PSO, if you get good bony contact, you have a cage below and you have posterior contact, the non-union rate is very reduced. But we have had also surprises. Some cases with anterior fusion, with anterior continuity of the trabeculae, that after 9 years failed and broke the rods. So I think nothing is sure in this,
right.
this panorama.
What about, do you use only that osteotomy, corner osteotomy, and not use others?
No way, by no means. We try to minimize the amount of 3-column osteotomies. So whenever we can get a correction with only Ponti osteotomies, or combining anterior procedures, for example, hyperlordotic A-leaf or hyperlordotic D-leaf, and posterior closing osteotomies of the posterior column, we prefer that because the surgical risk is substantially reduced. Of course, for very severe cases, we need to do DCR, but this is not the topic of this discussion. In some cases where we need a 3-column osteotomy, but for small corrections, like 25 degrees, I avoid corner PSO because with corner, it's easy to overcorrect. So we do all the spectrum of osteotomies.
Do you have any preference of the level? That means, do you recommend to do this corner osteotomy only at L3 or L4 or L2, or is it really dependent from where the deformity is localized?
Yeah, as you say, it depends on where the deformity is. In most cases, the deformity, the loss of lordosis is in the lower lumbar spine. We always aim to get a restoration of the Rusuli type. So in most cases, you need more lordosis between L4 and S1. So the most frequent level for corner PSO is L4. Today I did a PSO in L5. Sometimes we do it in T12. It depends on the deformity place.
What about mid-thoracic levels? Do you ever use it in mid-thoracic?
Mid-thoracic, I don't think that this is a natural environment for corner PSO because vertebrae are very tiny. So actually, when you release the vertebra, you can get almost any correction with especially if you use a domino technique for compression between the two segments of the spine.
And did you use cage level of osteotomy if the end place not too close bone to bone?
Very uncommonly, because usually you can compress to get contact between the end plates.
But when do you prefer to place a cage?
Very uncommonly, if I do the mistake of doing a parallel osteotomy, so the height of the vertebra I resect posteriorly, is almost the same height I resect anteriorly. I remember one case. So it was actually a shortening osteotomy, not a lordosing osteotomy. In that case, I needed to use a cage anteriorly, which is almost a VCR procedure.
Okay. Honor want to tell something. Honor.
First of all, I'd like to thank Aebi to give us the opportunity to share our knowledges on OOT platform, and to Pedro. At the beginning, he told us that he learned this technique from Lehek, and I have learned this technique from Pedro. So,
well, what I have learned a lot of things from Jean-Charles Lehek. Regarding corner osteotomy, I didn't learn this from him. What I learned from him is that having contact posteriorly between the lamina is a thing you want to get to
yes,
increase the fusion rate.
Pedro,
But I have learned a lot of things from Jean-Charles.
The thing that we have to learn from you is these procedures are bleeding procedures. Do you have any trick to decrease the amount of bleeding during the surgery?
Yes, I think that some things we do. First thing is to avoid the patient getting cold. If the patient goes to 35 degrees of temperature or 34, there will be no coagulation. So we keep a lot of attention to keep the patient warm during the surgery and during the preparation. Sometimes the anesthesiologist prepares the patient, and when the patient goes to the room, it's 34 degrees and there's no coagulation. First thing. Second thing, being maniac in doing hemostasia in the approach phase, because if you don't do that, then at the end you have lost the credit of bleeding for the surgery. Third thing, during the osteotomy, I prefer using big tools. If you do all the resection with the Kerrison Rongier, you will spend a lot of time, there will be much more bleeding. So I use chisels, and I use sometimes ultrasound chisels or scalpels. Sometimes we use bars to reduce the bleeding. The fourth thing is in the epidural space, always do working at one side, coagulate the epidural vessels aggressively, cutting them, because when you cut them, it seems like they stop bleeding after a while. So I cut them, then I pack a sponge of gel foam with a cottonoid. I go to the other side, work there, then pack gel foam and cottonoid and go to the first side, and so on. By doing this, I think we can reduce the bleeding. And the last thing is using some of these fibrinogen, thrombin preparations like FlowSeal or Surgiflow. If we have a low threshold for using them, you save a lot of blood units at the end.
Yeah. Pedro, there is a repeat question, but they want to know, to tell you that exactly Dr. Ahmet Al-Khatub is asking, is that osteotomy applied only for lumbar spine?
Mostly yes. Mostly yes. We do also in the lower thoracic spine, but usually in the mid thoracic spine, we prefer, if we need very strong corrections, we prefer vertebral column decancellation, for example. So yeah. I think that if you go to, sometimes in T9, you want to do a corner osteotomy, usually not higher.
Yeah. Haluk is asking, do you use tranexamic acid? If yes, what is your protocol?
Yeah. I cannot tell you the details because it's something that the anesthesiology team usually cares. I am very careful about the temperature, because the temperature of the patient is what everyone is forgetting, and it's what makes the difference. Tranex makes some difference, but the temperature is the key.
Yeah. The last question probably, how do you decide which level to perform the corner osteotomy?
Well, as I said before, it depends on the on where the deformity is. For example, if you have 30 degrees or 40 degrees of kyphosis between T12 and L2, you need to do the osteotomy in the thoracolumbar junction. If you have, the most common cases are lumbar flat back, where you lose the lordosis between L3 and S1. And in those cases, usually the best level is L4, because by doing this, you restore the normal distribution of the lordosis. But the goal is fixing the deformity and, correcting the deformity and restoring the original Russoliti type of the patient.
Yeah, that's fine. Yeah. Thanks a lot. Is there any question, Professor Aebi?
No, I think he explained it very well, and I think the most important questions have been asked. I might propose that we try whether Jean-Charles can present, and then after his presentation, maybe there will be even more global discussion where we would like to ask Pedro also to participate.
Yeah, exactly.